Hello there, this is John, and this is the Cardiac Arrest Management Lecture. I know you've already been through your CPR classes, and you probably have a good understanding of how to perform compressions and ventilations. But good, effective cardiac arrest management takes a lot more than just pushing on the chest. First and foremost, you need a really strong team leader, one who can delegate roles, and then once those roles are put in place, make sure that those crew members are doing their jobs correctly, making sure the compressions are the right depth and the ventilations are going in and all that. And while the team leader is ensuring all of this, they have to think about things like communicating with the survivors, letting them know what's going on, the progress, asking questions about the patient's preferences and things like that. And of course, at some point, they're going to be talking to the base hospital about the patient's outcome. Are they going to transport? Are they going to have the patient pronounced at scene? So a lot of things are going on simultaneously. It's not just pushing on the chest. And when it comes to location issues, if you do have an extrication issue, like the patient's at the bottom of a ravine, they're at the top of Cowles Mountain, and you got to hike a half a mile up into the mountain to get this person. Maybe law enforcement is there, and maybe they're possibly the cause of the cardiac arrest. They shot the person, or the person was involved in a high-speed crash because of a chase. Now you're dealing with the dynamics of, now you have a person who was killed by law enforcement. It really heightens the whole thing. They're going to want to think about evidence and preserving evidence and documenting everything. And they might not even let you come near the patient until they clear the scene, when it comes to scene safety anyway. So you might be waiting for them to do what they have to do before they'll even let you in to do your CPR, to do your compressions and all that. And think about public places, like, it's a Padres game at Petco Park. Someone drops dead there. It's at the beach, like on a Saturday in the summer. They're on the trolley. They're downtown on the street. So these are all public places. You, as a team leader, along with all these other things going on simultaneously, you have to decide, okay, do we move this person? When do we move this person and get them out of public view? What are the scene safety issues with the crowd and all that? And on top of all of this, you're thinking about resources. You're thinking about, what am I going to need 5 minutes from now? What am I going to need to get this call going 10 minutes from now? So I need an ambulance. I'll need a gurney and a backboard, and I need some more crew members to come in to help me extricate or move. So the earlier you call for these resources, the sooner obviously they'll get there, and the more efficiently this call will be ran. And you can see that a lot of the agencies in the county now use either the Lucas or the Auto Pulse, and they've kind of taken away that compression factor for us. So now it's done mechanically, which relieves, obviously some of the crew members from the burden of doing this. They do have their drawbacks. They do fail sometimes. They're installed incorrectly. So it just really depends upon the crews and all that. But ultimately, they work pretty well. When it comes to why people go into cardiac arrest, there's just two main problems. One is it's an electrical issue, or the other is a mechanical issue. And really, depending upon the cause, will dictate how we treat this person. So when it comes to when the person has some kind of electrical issue, it just means that the heart is more than likely been denied oxygen, and the heart muscle has died, and they go into cardiac arrest. So this is a medical problem, like a myocardial infarction, like a heart attack. Someone has gone through a drowning event, they're dead because of the hypoxia caused by the drowning event. The electrocution is the heart was shocked into a non-viable rhythm, and hypothermia is this kind of the same thing. The heart becomes so hypoxic that it just essentially stops. The one exception to all this is, and it's called commotio cordis, and this is caused by blunt force trauma to the chest. And because these these impacts are really not high velocity impacts. So this is seen a lot in sporting events where two players bump together, a basketball game, football game, soccer, those types of things where one player hits the other person in the chest. That impact causes the heart to go out of rhythm and usually goes into what's called a ventricular fibrillation. So this is a young, healthy person normally with a strong heart, and they didn't die from a heart attack. They went into cardiac arrest from this unfortunate impact. And the impact doesn't cause any permanent internal injuries. It just disrupts the electrical conduction of the heart temporarily. So if you can get compressions going on this patient, if you can get the AED attached quickly, they respond really, really well to this situation. This is why you're going to see a lot of high school, junior high school, college sporting events. There's going to be someone on the sidelines carrying one of these AEDs, and because this is unfortunately does happen, every once in a while. Other reasons, of course, is an overdose. Stimulants, opioids, depressants, again, eventually all of these will cause hypoxia to the heart, cause damage to the heart, and they go into cardiac arrest. Now, the mechanical problem, this is physical damage to organs. This is the person who gets shot in the chest 3 times and the bullet goes right through the heart, right through the aorta, pops both lungs. So they have irreversible damage to their internal organs. And from a serious, high impact, traumatic injury. So we're still going to go through compressions and ventilations, but because the organs are damaged, attaching the AED is not going to really help them. So we actually forego that. We do compressions, ventilations. We might transport, depends on the circumstances. But again, this is major organ damage. So our treatment does vary. Again, trauma versus medical and all that. And when it comes to downtime, if we can find out how long the patient has been without a pulse and no one's done good, effective compressions, it really tells us their possible chance of survival. The longer they're down without a pulse, the less chance they have of survival. So after about 10 minutes, if you go into cardiac arrest and no one's done anything for at least 10 minutes, your chance of survival is almost zero. You've you're way past the curve at this point. Signs of cardiac arrest, well, obviously they don't have a pulse, or you don't think you can feel a pulse anyway. But remember, people who are in cardiac arrest can still have gasping respirations, gasping, labored breathing, and it might fool you. You might say, hey, this guy's breathing, he must have a pulse. Check and see, because he might not have one. If you check the pulses and you think you might feel something, but you're not sure whether it's twitching or whether it's a muscle or whether it's a pulse or whatever it might be, if you're not absolutely certain, when in doubt, start CPR. If you think about it, if they do have a pulse and their pulse is so hard to feel, that means their blood pressure is really, really low. So if you can't feel a pulse or you're not absolutely certain what's going on, start compressions and ventilations. It can only really help them. When it comes to the American Heart Association chain of survival, these are the steps that people go through that have the best chance of survival of cardiac arrest. Someone recognizes this person is in cardiac arrest, they activate the 911 system, they start compressions, they attach the AED, ALS arrives, ALS transports, gets a pulse back, they get post-ROS care, and they go into recovery rehab. And this is that window of opportunity that gets them out the door and surviving and back into society. It's pretty rare that this actually happens, or people actually walk out of the hospital after a cardiac arrest, but it does happen occasionally. Sudden infant death syndrome. So this is the diagnosis of last resort after an infant has died. And remember, the term infant means any child from newborn to 12 months in that area. And when an infant has died and there's no obvious reasons why they've died, they go to the coroner's office and they get an autopsy, and the coroner decides they've checked everything out, everything's negative. So it's the diagnosis of last resort. The coroner is going to say this is a SIDS baby because they just don't know what caused this child to die. This happens mostly between the age of 1 month and 4 months, the most common period of time, the highest risk, I guess, to these children. Back in the 90s, prior to like 1994, 1995, there was an average of 10,000 SIDS deaths in the United States on average every year. After the federal government started this Baby on Back program, where they were now teaching the mothers and fathers that when the child sleeps, they should sleep on their back until they can roll themselves over, which is past that 4 or 5 month period anyway. And after they started this Baby on Back program, within a few years, it had dropped the average SIDS death to about 5,000 annually, which it remains today, actually. So there's still quite a number of SIDS babies that die every year in this country. If this child has died, we don't know exactly whether it's a SIDS or not. We don't know whether this was suffocation or some type of some kind of abuse, those types of things. So we're going to start compressions and ventilations. We're going to attach the AED as long as there's no obvious signs of death, rigor mortis, and things like that. If the child is in cardiac arrest and they don't recover, wherever they are is a crime scene. So if you're still in the residence where you found the child and the child's not viable, the child is stiff and cold and beyond help, or you perform CPR for a few minutes and you determine the child's not viable, then it becomes a crime scene. Hopefully and luckily, I almost guarantee you're going to have police officers show up either right then when you show up or within a few minutes. They're going to be there to help you do this. They're going to seal off that room. And then once the coroner comes and retrieves the infant, does a full autopsy, makes the determination that this was or was not a crime, then of course, the family can move on from there. So there's always a big question of like how CPR works. If you really think about what you're doing when you are performing compressions, it might give you a better idea of like why it's so important to do effective compressions and ventilations. So you have these 3 phases of cardiac arrest. So the electrical phase, the circulatory phase, the metabolic phase. So the one on top here, the electrical phase, you'll notice that this rhythm you see is ventricular fibrillation. It's very coarse. It's very active. This is the first 4, maybe 5 minutes of the cardiac arrest. So this is the first 5 minutes or so of this person going into cardiac arrest. The heart muscle is still oxygenated. It still has glucose. It still has a lot of electrical activity. So it has this very coarse, very active looking rhythm. If no one does compressions or ventilations for 5, 6, 7 minutes or so, this person will start to degrade into the circulatory phase, which is the middle strip right here. That rhythm, right, that you see right there, is still ventricular fibrillation. It's the same rhythm as the upper one. The difference is the amplitude, the strength of that conduction has been reduced dramatically because the heart is now hypoxic. And this is when you start seeing lysing of the cells, cell damage due from hypoxia. And then, of course, if still no one does anything, no one starts compressions or ventilations, this will within 6, 7, 8, 9, 10 minutes, they're going to be degraded into the metabolic phase. And now you have permanent cellular damage, massive cardiac or heart muscle damage, and the heart just essentially stops, and they go into the metabolic phase and they go into asystole, that flat line you see right there. So what American Heart Association learned way back when in 2001, and which they've updated in the last few years, is that if you find someone in the circulatory phase and you do effective compressions and ventilations, you have good deep compressions with complete recoil of the chest, what this does is it reperfuses the heart muscle, and it can actually put them back into the electrical phase and make them more receptive to defibrillation. Because your best chance of survival is that first 4 or 5 minutes of cardiac arrest. If you can get to this person within 3, 4, 5 minutes of their arrest and do effective CPR and attach the AED, they're more than likely going to be in this electrical phase, and they will respond on your first or second shock and get them back to some kind of viable pulsed rhythm. So it's really, really important that you keep them from going into this metabolic phase, because once you're in this metabolic phase at the bottom, they're already been 8, 9, 10 minutes into this, or even longer into this cardiac arrest without any kind of intervention. They're beyond help. They're not going to recover. The two shockable rhythms you've already learned about is ventricular fibrillation, the upper one, and then VTAC, which is the bottom one there. Both, obviously, you'll have your AED attached. The AED does not have a rhythm generator screen, so you're not going to see the rhythm. But the machine will say shock advised, shock advised. You're not going to know what you're shocking, but it's some type of one of these two shockable rhythms. And of course, when you're in this, metabolic phase, this person is now in asystole. This is a non-shockable rhythm. There's nothing to shock. The heart is dead effectively, and they will not recover. And this is seen when someone's had a long or prolonged downtime, 10, 12, 15, 20 minutes, and no one's done any intervention. The one at the bottom is called pulseless electrical activity, and it's also not a shockable rhythm. And this is seen predominantly in traumatically injured patients. This is a person who has serious internal organ damage. They've lost a lot of blood. And even though the heart muscle is still pumping, you still have this activity going on, this organized activity going on. But because there's no liquid getting back to the heart, the pump's not working, and there's no pulse associated with this rhythm. So this predominantly is associated with either blunt or penetrating trauma to the chest, like someone who crashes their car and with no seatbelt and slams into the steering wheel, or someone who's been stabbed multiple times in the chest. Things like that are going to cause this to occur. So when it comes to your AED, you're going to check it out every morning, start of shift. Make sure that the batteries are all fully charged. Make sure that you have spare batteries. Make sure you have your defib pads are not expired. You have at least a couple of each, there. Everything that you need that your department wants you to have, essentially, with that. And deciding when to transport this patient, or even if to transport this patient, is going to be kind of up to you as the team leader. So if at any time someone's in cardiac arrest, if you get a pulse back on them, it's time to move them towards the hospital. Keeping the AED pads on them, maybe performing bag valve mask ventilations, because they're maybe not, even though they have a pulse, they might not be breathing effectively. And you're going to transport them close to the closest STEMI center so they can be evaluated. This is a medically related or type of cardiac arrest. If this person's still without a pulse, after about the second or third no shock advised, and they still have no pulse, it might be time to move them towards the hospital. Get the spine board and the gurney and start loading them up, moving towards the hospital. If you've given them a couple of shocks, you're on the second or third shock or defibrillation, it's time to move them. So you're going to be at scene for at least 10, 12 minutes or so before you move them, because realistically, this is their best chance of survival here and now. As soon as you start moving them, you degrade the effectiveness of your CPR. So if you're moving them from the floor to the gurney, you really can't perform CPR. They're on the gurney. It's very hard to perform good chest compressions when they're on the gurney, wheeling out to the ambulance. And then once you're in the ambulance driving to the hospital, all the bumpy roads and the tight compartment and all that, doesn't really make for a good platform for effective CPR. So if this person is going to survive, it's going to be here and now at scene. And hopefully you found them in that first 4 minutes or 5 minutes of the arrest where they're in the electrical phase. And so just keep that in mind. Like you have to make that decision yourself. Like when am I going to transport? We usually don't just scoop and haul and run off the scene on these patients because these are medical patients with a medical complaint. If this person has been shot in the chest or they have massive blunt force trauma from a fall from height, then these patients, we are going to start compressions and ventilations. We will not attach the AED because, again, it's not going to be a shockable situation. But we will transport them rapidly to a trauma center if we feel they have any kind of viability about them. There's a lot of people who die from blunt force trauma and penetrating trauma that never really get transported because, again, like the organs are so damaged, they're probably not viable. But it depends on your state laws and your protocols and how your county addresses this. Anyone in cardiac arrest due to a medical cause or an electrical cause should go to a STEMI center. STEMI stands for ST elevation myocardial infarction, and they're going to be able to treat this person there. If you do get pulses back, then obviously they need to go to a STEMI center as well. On the way to the hospital, you should think about keeping the oxygen levels, pulse oximetry levels around 92 or greater. In that range is ideal for these cardiac arrest patients that have gotten pulses back. Keep the defib pads on. You need some kind of spine board or something under them on the gurney to give you some type of a firm surface to do effective compressions if they have not had their pulse return, or if it does in the future, maybe they go back to cardiac arrest. If they do get a pulse back, your priority vital sign is a blood pressure. And usually when a person gets a pulse back initially after cardiac arrest, their blood pressure is going to be really low because the heart's just trying to get restarted, trying to start pumping, kind of catch up with, what the pressure drop due to the cardiac arrest. So the initial blood pressure is going to be really, really low. As the heart starts pumping more and more, the pressure will more likely come back up to something fairly reasonably normal.